Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Bert Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Bert Kushner.
Welcome, viewers. I'm Bert Kushner, and I'm the moderator of this One World, One Vision comprehensive course on strabismus, and today's lecture on new anatomical concepts with respect to strabismus. I imagine some of the viewers are new to this series, and if so, I'm glad you're here. I imagine many may be former viewers, and if that's you, welcome back. Today, we are most fortunate to have Joe Demer from UCLA presenting this lecture. I think that Joe, more than anybody in our field, has taken basic science concepts, most of which he made the original observations on, and translated them into practical applications that we can all use in our management of strabismus. I think his contributions have been truly monumental. Dr. Demer is not only an MD, but he has a PhD in Biomedical Engineering. He's currently the Chief of Pediatric Ophthalmology and Strabismus at UCLA Stein and holds the Rosenbaum Professorship of Pediatric Ophthalmology. He's also a professor of neurology. In 2003, ARVO awarded Dr. Demer the Friedenwald Award for research on the extraocular muscles and orbital connective tissues. He's truly one of the very few pediatric ophthalmologists who has been so honored. He's published over 308 peer-reviewed publications, an astonishing number, 44 textbook chapters, and I learned that his work has been cited in the literature over 16,000 times. That is amazing. He's trained more than 250 ophthalmology residents, 80 clinical fellows, 20 research fellows, and has chaired 6 PhD committees. I think more than anyone, he has really brought basic science to the clinical realm and has had a direct and daily impact on our treatment of strabismus. So it is with great pleasure that I turn this over to Dr. Demer.
Thank you very much, Bert. It's a pleasure to be able to be included in this excellent program that you have arranged. Now, I'm going to begin by talking about old anatomical concepts. This is a wooden model, an ophthalmotrope, showing the extraocular muscles as rotated by strings. This is from the Columbia University Museum, and it was a model in the possession of Philip Knapp. And it shows what the concepts of extraocular muscles have been since around the 18th century through the end of the 20th. But lately, we've been able to re-examine some of these structures and add detail beyond which Knapp was able to achieve. Now let's review some of the actions of the extraocular muscles that are classical and are still correct. The primary action of the medial rectus muscle is adduction, rotation toward the midline. The primary action of the lateral rectus muscle is abduction, the opposite, rotation away from the midline. The superior rectus primary action is supraduction, elevating the eye. The inferior rectus primary action is infraduction, rotating the eye downward. The superior oblique's primary action is encycloduction, that is, twisting the superior pole around the line of sight toward the midline. And the inferior oblique's muscles' primary action is excycloduction, twisting the superior pole of the eye away from the midline. The secondary actions of the extraocular muscles are seen in the lower right corner and are also important. The superior and inferior rectus muscles are adductors as secondary actors, and the oblique muscles have vertical actions. The inferior oblique muscle is a supraductor, or upward rotating muscle, while the superior oblique muscle is an infraducting, or downward rotating muscle. The tertiary actions of the muscles are seen in the lower left corner. For the inferior rectus, excycloduction. For the superior rectus, encycloduction. For the inferior oblique muscles, AB or adduction, depending on the horizontal position of the eye. The same is true of the superior oblique muscle. That gets to be complicated, but the tertiary actions are not very important clinically. I was very confused as a student as to why the vertical actions of the oblique muscles are opposite their names. And the reason is that they insert posterior to the equator of the globe, moving the back of the eye in the direction of their namesake, and thus the front of the eye in the opposite direction. And this model demonstrates the path of the superior oblique muscle, which has an inflection in direction in the trochlea, as if its functional origin were antero-nasal rather than in the deep orbit at the annulus of Zinn, where the rectus muscles all originate. The superior oblique muscle has some interesting anatomy to which we will return. This is a specimen that was prosected with the help of Robert Goldberg and several others in our laboratory and excised from a cadaver en bloc. And here we see it laid out along with the cartilaginous trochlea. Now, it's possible to slit the trochlea and remove it, and when you do that, you can unroll the tendon of the superior oblique muscle and find that the structure of the superior oblique muscle is very similar to a rectus muscle with a long tendon. I will return later to the topography of the fibers of the muscle belly in relationship to the fibers of the tendon, because that turns out to be important functionally. This is a demonstration in a normal subject using quasi-coronal magnetic resonance imaging with T1 weighting in 5 gaze positions: central gaze in the middle, adduction on your left, abduction on your right, upward gaze, which is supraduction at the top, and downward gaze, infraduction at the bottom. We are stepping through in 2 millimeter intervals through the entire orbit. And we've colorized this image in a hot iron kind of a color scheme in order to make it more interesting. Note that we can see the cross-section of the 4 rectus muscles, and in the upper left of each panel, the superior oblique muscle. Let's look at the adduction panel on your left. Note that in adduction, the medial rectus muscle has a larger cross-section than the lateral, and the optic nerve swings to the right. In abduction on your right, the lateral rectus cross-section is bigger than the medial rectus, and the optic nerve swings in the opposite direction to the left. Now, look both at the adduction and the abduction images at the horizontal position of the vertical rectus muscles. Do you notice that regardless of the horizontal position of the eye, there is no horizontal shift in the position of the vertical rectus muscles? Now let's look at the top and bottom panels. In upward gaze, in mid-orbit, you see a thicker superior rectus muscle and a thinner inferior rectus muscle. In the bottom panel, conversely, you see a thicker inferior rectus muscle and thinner superior rectus muscle, and the optic nerve swinging in the opposite direction of the designated gaze direction, which represents where the cornea is pointed. In the top and bottom panels, now look at the paths of the horizontal rectus muscles. The horizontal rectus muscles are not shifting vertically. Their paths are stabilized. So the four rectus muscles in the deep orbit do not change their positions noticeably in response to large horizontal and vertical rotations of the eye. And this stable behavior is a consequence of the pulleys and is extremely important to the kinematic behavior of the eye, and thus our ability to make the eye straight with strabismus treatment. And let's illustrate that here with this concept. It's very important. The rectus muscles have connective tissue pulleys that are made of sleeves in Tenon's fascia, but depicted here by small black rings surrounding the schematic colored rectus, and in this case, purple superior oblique muscles. These pulleys are composed of collagen, elastin, and smooth muscle. Their locations are very stereotypic because they serve as the functional origins of the extraocular muscles and determine the pulling directions of the extraocular muscles just as importantly as the scleral insertions on the eyeball determine pulling directions. The pulleys stabilize the muscle paths and regulate them so that the rotational properties of the eyes can be controlled by the brain. The active pulley hypothesis is actually an important biomechanical concept that helps us to understand the kinematics or the rotational behavior produced by the extraocular muscles via their pulleys. Now, extraocular muscles have two layers. One layer, the global layer, inserts on and rotates the eye. The orbital layer inserts on and translates the front to back or anterior to posterior position of the respective pulley. The pulley shifts anteroposteriorly in coordination with the scleral insertion, and pulley shifts make muscle pulling directions change with gaze. Systematic changes in muscle pulling directions are necessary for the neural regulation of binocular alignment, and it is fortunate that connective tissue pulleys can be manipulated by eye surgeons for the benefit of the patient. Now, the pulleys act as the functional origins of the extraocular muscles, as seen in this colorized pair of axial MRI scans of the same right orbit imaged in abduction on your left and adduction on your right. Note that the path of the medial rectus muscle in abduction has two straight line parts in different directions. From the scleral insertion to a point in the anterior orbit, the muscle is pulling parallel to the small white arrow that you see in the middle. But posterior to that point, after a hook or an inflection, the muscle runs directly toward the orbital apex at the bottom of the screen. Now, in adduction, you see two different paths of the lateral rectus muscle. One which follows the nearly vertical line that says LR pulls from the scleral insertion to a point in the orbit laterally where there's an inflection, and then the lateral rectus muscle runs directly posteriorly toward the annulus of Zinn. In abduction, and the medial rectus muscle, and in adduction, the lateral rectus muscle pull in directions substantially different from the direct line from the insertion to the annulus of Zinn. And that difference in pulley direction is really important to the rotational action of the extraocular muscles. And here's kind of a quick explanation called the active pulley hypothesis. The global layers of the muscles insert on the eye and rotate, so only half the muscle actually rotates the globe. The other half of the fibers do not insert on the globe, but instead insert on the pulleys and shift them anteroposteriorly, retracting the pulleys when the muscles contract. The orbital layer of the inferior oblique muscle inserts on the inferior oblique sleeve, the inferior rectus pulley, and the lateral rectus pulley, and the orbital layer of the superior oblique muscle inserts on the superior rectus pulley via the superior oblique sheath, which passes through the trochlea. The pulleys reconfigure themselves for certain physiologic functions like the vestibulo-ocular reflex and convergence. Here's a demonstration in a cadaver of the medial rectus pulley. Now look on the left side. This is like a surgical photograph where we've opened the conjunctiva at the limbus and put a hook under the medial rectus tendon or muscle, as it is labeled here, and you can see some slings of connective tissue that are white that are running anteriorly toward that point. I've actually disinserted the origin of the medial rectus pulley suspension in the right side of that left panel and placed it on some white sutures. Now, in the right photograph, we've applied considerable traction to the pulley and torn it open, and you can see the opening posterior Tenon's fascia through which the muscle passes into the deep orbit. This demonstrates a stretching of the pulley ring, which should not be performed, of course, in living patients, but in cadavers, it's a good demonstration. Here is a surgical photograph from a case that I did in which I made a limbal incision and placed a hook under the insertion of the medial rectus muscle with some blunt dissection of the posterior connective tissues to the point where we see the insertion of the orbital layer in the glistening white connective tissue that constitutes the very anteriormost portion of the medial rectus pulley. You can see little fibrils of the muscle fiber running into that connective tissue if you look hard at it. Here is a pair of T1 weighted MRI images of a normal left orbit. Look at the image on the right first. I've injected gadodiamide contrast in this case, and gadodiamide produces a bright white signal in tissues that are highly perfused, such as the ciliary body and the choroid. But you also see some bright signal in the anterior part of the medial rectus muscle. Now, using a higher quality technique on the left with special surface coils, you can see these details better. Note that the anterior part of the medial rectus muscle fibers are highly vascular, so they have a bright signal, but they are surrounded by a darker, less vascularized medial rectus pulley that's made predominantly of collagen and not muscle fibers. So this is a high-power view of the medial rectus pulley as seen here, denoted by the arrow. ON stands for optic nerve, MR medial rectus muscle, LR lateral rectus muscle. A coronal view of the same medial rectus pulley in a right orbit is seen here. Once again, gadodiamide contrast lights up or provides bright contrast in the choroid, but also in the muscle fibers of the medial rectus at the pulley. But you can see that the medial rectus muscle fibers are surrounded by a ring or encirclement of dark tissue that is the relatively avascular collagen of that medial rectus pulley ring. In the cadaver, we can take a transverse section of the medial rectus pulley and stain it with Masson trichrome, a stain which stains the collagen blue and muscle fibers in various shades of red. We can see here that the orbital layer fibers to the left side of the small arrowheads inside that pulley ring are finer and darker staining, but as I will show you, they are actually inserting on the interior of that pulley ring. The global layer fibers on your right are larger and slightly brighter staining. They are transiting the pulley. They will run through it and ultimately transition to tendon fibers that insert on the eye to rotate it. Here is a coronal section of a normal human orbit stained with Masson trichrome, in which the collagen stains blue and the muscle fibers are staining red. You can see that the vitreous has collapsed, producing an artifactitious retinal detachment, as is the case in most cadaveric human specimens. The blue of the sclera is readily evident, and we can see the four rectus muscles. On your left, we have the medial rectus muscle, At the bottom, the inferior rectus, and to its right, the inferior oblique muscle. Horizontally at the far right is the lateral rectus muscle, and superior to it is the orbital lobe of the lacrimal gland. At the top, adjacent the globe, we have the superior rectus muscle, and above it the levator. And you can see that all four rectus muscles are inserted by rings of blue staining collagen, as well as the sheath of the inferior oblique muscle and a sheath around the superior oblique muscle at the upper left. Note that the levator palpebrae superioris, the lid lifting muscle at the very top, does not have a pulley. There are also some ligaments or connective tissue bands that interconnect the four rectus pulleys. The most important is in the upper right, which is the LR-SR band ligament. More about that will come later in this talk. Here we have a coronal MRI image done with T1 imaging of the same perspective of a left orbit. We can see the MR medial rectus, LR lateral rectus, IR is the inferior rectus muscle. And note with the gadodiamide that's been injected, we see highlighting of the muscle fibers within the lateral rectus pulley, the pulley tissues being black because they're fairly avascular. But note here the path of the inferior oblique muscle denoted IO. There's a straight line path at the lower left of that inferior oblique muscle to a point just lateral to the inferior rectus muscle, at which there is an inflection in direction of the inferior oblique muscle where it follows a more or less straight line path to the insertion on the sclera. That inflection point is the pulley of the inferior oblique muscle, and it corresponds anatomically to the entry of its motor nerve. So that's the inferior oblique pulley. Now we can demonstrate the inferior oblique pulley readily at surgery. This is a left orbit as seen from a surgeon's perspective. So the conjunctiva has been opened. There's a muscle hook placed beneath the inferior rectus insertion, and the inferior oblique muscle has been disinserted and attached to those two dark sutures that you see on the far left. If you follow the muscle forward, you can see just at the border of the inferior rectus muscle a vertically oriented white band that constitutes the pulley of the inferior oblique muscle. That's what produced that inflection in the MRI scan. And here's a video showing such a case where the disinserted inferior oblique muscle is running to the pulley regardless of the direction of the disinserted end. The muscle runs toward the pulley. The pulley locations of the rectus muscles are quite stereotypic across individuals. So here we see the horizontal coordinates on the x-axis and the vertical coordinates on the y-axis of the four rectus pulleys with the origin at the center of the orbit. The pulleys were located in, and this is the average of about 12 individuals, in primary gaze in the circle, in up gaze, adduction, abduction, and in down gaze. Notice that the medial rectus pulley is highly stable within the orbit. It doesn't shift. There are small shifts in the superior rectus and inferior rectus pulleys, and notice that there is some shift vertically in the lateral rectus pulley, moving upward in down gaze and downward in upward gaze, a direction opposite the great circle or shortest path over the globe. These shifts are much smaller than would be the case had there been no pulley constraint on the paths of the muscles. I asserted earlier that the extraocular muscle insertions are bifid, and here is a nice demonstration in an eye that is clearly pseudophakic. You can see the intraocular lens. This is T1 MRI imaging. You see from the medial rectus muscle, the global layer inserts on the globe. The orbital layer inserts at the base of that fork seen in the upper left. That's the location of the pulley. This is a sagittal view of a normal individual in three vertical gaze positions. And I want you to note two things. We have a very nice demonstration of the inferior oblique muscle, which is seen at the bottom. You're cutting it transversely, and also the inferior rectus muscle. And you can actually see the bright fissure between the global layer of the inferior rectus muscle, that's the upper part, and the orbital layer at the bottom, with the bulk of the contraction in downward gaze occurring in the orbital layer, because the orbital layer does more work than the global layer, at least in maintained static gaze that was done here. Note that the inferior oblique muscle shifts anteriorly in upward gaze and posteriorly in downward gaze. So the inferior rectus muscle controls, to a large extent, the position of the inferior oblique pulley, which is an interesting and important interaction. Even in the absence of a normal eye, the pulleys have their effect. This is a case in which the left eye was enucleated for a malignant choroidal melanoma and replaced with a sphere of coralline hydroxyapatite to maintain bulk in the orbit. There is also a solid black artificial eye, a prosthesis, present between the lids anteriorly, but since the prosthesis has no mobile protons, it gives no signal and looks black on MRI. This is T1 weighted MRI with gadodiamide injection. You can see the enhancement of the ciliary body and the choroid and some of the extraocular muscles. Now, gaze direction, of course, is controlled by fixation by the right eye. There is nothing to view on the left, but note the path of the medial rectus muscle. Do you see in the upper right and to a lesser extent in the lower right a sharp, almost 90-degree inflection in the path of the medial rectus muscle, which is normal posterior to the pulley, but then transitions more anteriorly in an almost horizontal fashion to where the tendon was sutured surgically to the surface of that coralline implant. So pulley effect does not require the globe. This is a transverse micrograph of a human medial rectus muscle in its pulley stained with meson trichrome, so that collagen stains blue and muscle stains purple. And the color of staining of the orbital layer is a little darker purple in the orbital than in the global layer. In the 10-micron section immediately adjacent to this one, we've used Van Giesen stain for elastin to demonstrate the black elastic microfibrils, which are particularly concentrated in the pulleys. Elastin has the property of reversible extensibility, so it's got a memory, and it tends to be located in tissues that are under high mechanical stress. The little rectangle is a region that we're going to magnify and look at higher magnification. So this is a high-power view of the medial rectus stained with meson trichrome. The little red dots are individual myofibers of the orbital layer that are becoming embedded within the inner surface of the collagenous pulley. And in the adjacent serial section, we can see at higher power, the elastin microfibrils are acting like little anchors or staples to anchor the orbital layer fibers into the pulley in an area that is reinforced to accept their muscle attachment. This is a longitudinal section of a human lateral rectus muscle at the pulley, again stained with meson trichrome. The global layer is seen at the bottom. It runs posteriorly from your right side toward anteriorly on the left side, transiting the pulley, whereas the orbital layer terminates within the pulley, and you can see that it's inserting in the interior of the pulley at the location of those 4 arrowheads at the top. The inferior oblique is a complicated muscle, and this is the only example of a non-human specimen that I'm showing you because it was possible to do this with very high histological quality, but the same findings occur in humans. The arc-shaped section is a coronal view or longitudinal view of the inferior oblique muscle of a Nemestrina monkey, showing that the inferior oblique muscle has 2 layers. A global layer that's higher and an orbital layer with smaller fibers at the bottom. Both the inferior oblique muscle and the inferior rectus muscle are surrounded by sleeves, a pulley in particular of the inferior rectus muscle. And the insets demonstrate that the orbital layer fibers are inserting in the surface of the pulley sleeve in that middle panel, and the very top panel demonstrates that the orbital layer fibers are inserting in the inferior portion of the lateral rectus pulley, so that contraction of the orbital layer of the inferior oblique will tend to shift the inferior rectus pulley nasally and the superior rectus pulley inferiorly. The superior oblique, of course, is a unique muscle because it has been known since antiquity to have a rigid or cartilaginous pulley. And let me show you some of its structure. The superior oblique muscle has an orbital and a global layer, but in this case, the global layer is in the core of the muscle, and the orbital layer runs around its periphery like the bark of a tree. The sheath of the superior oblique muscle runs exterior to both layers, and in the anterior part of the orbit receives the insertion of the orbital layer fibers. You see on the left side a rectangle which was magnified in the upper right panel, stained with Meson trichrome so that we can see the individual fibers of the orbital layer beginning to insert in the inner surface of the superior oblique sleeve. And in the adjacent serial section seen in the lower right, stained with Van Giesen's elastin stain, we can see the black elastic fibers anchoring the muscle fibers to the inside of the superior oblique sheath. All of this is occurring posterior to the trochlea. And here we see what happens in the vicinity of the trochlea and anterior to it. So let's look first at the upper left image, which was stained with Meson trichrome. It shows the bright blue fibers of the superior oblique tendon, which have previously in the posterior part of the orbit received the insertions of the global layer, surrounded by the grayish blue sheath of the superior oblique tendon. That's posterior to the trochlea. In the upper middle, we see the cartilage, the semilunar shaped cartilage of the trochlea, and the superior oblique tendon is cut twice because it's cut through the plane of section like a hairpin. On the right, you see the tendon and the sheath passing over the saddle of the trochlea, and on your left, we see the two more anteriorly. The superior oblique sheath is transiting the trochlea along with the superior oblique tendon. And in the broad image on the bottom, we see a coronal view, which shows the sclera of the eye at the bottom, the superior oblique tendon, which is now thin and dense, wrapping over the sclera between the sclera and the superior rectus, and the superior oblique sheath on your right, broadly inserting on the nasal aspect of the superior rectus pulley, which encircles the red-colored superior rectus muscle. Thus, contraction of the orbital layer of the superior oblique muscle will tend to displace the superior rectus pulley nasally as the superior oblique muscle contracts. So let's look at a summary of the overall structure of the connective tissue system. And we're using as our navigator in the center a T1 weighted axial MRI upon which I've superimposed some labels. The global layers of the medial and lateral rectus muscles depicted here transit the bright blue rings of the pulleys before inserting as tendons on the sclera. The orbital layers of the lateral and medial rectus muscles terminate in the pulleys so that contraction of these orbital layers will retract the pulleys against the elastic suspensions, which are anchored more anteriorly against the bone of the lateral enthesis at Whitnall's tubercle and the medial enthesis, which is the posterior lacrimal crest. Now, in the upper left, we show a transverse cut of the orbit at approximately the level depicted by the upper red arrow pointing to the left. In this location, the extraocular muscle tendons are flat, and the slings that interconnect those tendons tend to be convex toward the orbit. This is the region where strabismus and retinal and glaucoma surgeons may operate and cut those connective tissues without disrupting the action of the pulley system. Now, more posteriorly, posterior to the globe, we see the area of the functional pulleys, and that histologic image is at the level of the middle red arrow, which is pointing downward to the right. Here, the extraocular muscles are encircled by the dense collagenous pulley rings. This is the level of the inferior oblique muscle and its pulley. And you see the suspensory ligaments, particularly the LR-SR band ligament that interconnect the superior rectus and the lateral rectus pulleys. This is the location of the functional origin, mechanically, of the extraocular muscles, which derives from the pulleys. In the lower left, we see a histological image taken at the level of the bottom red arrow, which is pointing downward to the left. only here do you see the four rectus muscles and the superior oblique muscle exhibiting both orbital and global layers, because the orbital layer terminates in the pulley and does not extend anteriorly to it. Note, there is no muscle cone. The muscle cone is a fiction which unfortunately persists in many anatomy and ophthalmology textbooks. There is no cone or membrane interconnecting the four rectus muscles. That simply does not exist. The only tissues in that area are loose areolar fat, and of course you've got the muscles, nerves, and the ciliary ganglion in the orbit. So a quick word about the ocular rotational axis and why the pulleys are important. The pulleys cause muscle paths to systematically change with gaze. So you see here that black stick that seems to be running like the pole of the eyeball. That's the rotational axis that will be produced by contraction of the horizontal rectus muscles. In this particular example, that blue lateral rectus muscle. Note that the rotational axis is tilting backwards by 1/2 of the vertical angle of the eye. That half angle behavior is like a magic number, which is significant to proper kinematic behavior of the eye and the ability of the brain to control the alignment of the eyes and binocular vision. So here's the concept here. If the distance from the pulley to the rotational, to the globe center is equal to the distance from the globe center to the scleral insertion, then the proper kinematic conditions are followed. And in this case, the schematized lateral rectus muscle is going to rotate the eye about that red vertical axis when it contracts. But if the eye looks upward by angle alpha, the criterion that must be met is that the rotational axis needs to be tilting backward by angle alpha divided by 2. So if the eye looks up by 20 degrees, the rotational axis needs to tilt backward by 10 degrees. Well, based on small angle trigonometry, that will happen if the distance d sub 1 from the pulley to the globe center is equal to d sub 2 from the globe center to the projection of the insertion on that horizontal line. So this is a criterion that must be fulfilled not just by the lateral rectus muscle, but by all the extraocular muscles to allow the eye to be controllable by the brain. And here's a demonstration that it actually happens. So here we have a right orbit of a normal individual imaged with T1 weighted magnetic resonance imaging in 2 different gaze positions. In the right column is 30 degrees adduction, where we have an axial image cut through the middle of the horizontal rectus muscles, and another one cutting through the path of the inferior rectus muscle at the lower right. In 30 degrees adduction, there's an 11-degree shift in the path of the inferior rectus muscle. Now look at the left column. In 43 degrees of abduction, there's an inflection at the pulley in the path of the inferior rectus muscle of 47 degrees. So there's a net 36-degree change in the path of the inferior rectus muscle corresponding to a 73-degree gaze shift. So the 36 is almost exactly 1/2 of that gaze shift of 73 degrees. And this is just one illustration of the way that the pulleys implement that magic half-angle rule that I talked about. Now, that works in just 2 different gaze positions. But if you need to maintain the distance between the pulley and the globe center equal to the distance from the globe center to the insertion when the eye is moving, then the pulleys need to move relative to the orbit. They need, if as it were, to fly in formation with the insertions without being attached to the globe at all. So that in adduction, seen in the lower right, contraction of the orbital layer retracts the medial rectus pulley, while the lateral rectus pulley is elastically allowed to displace forward to maintain the relationship of pulley to globe center to scleral insertion. And that allows the behavior of the eye to be controllable by the brain. The pulleys have to move forwards and backwards in the orbit, and that is why their orbital layers develop devote so much effort to shifting the position of the pulleys. So here's an example here in this schematic by Christian Kea, where the lateral rectus pulley is retracting posteriorly as the eye abducts so that the distance from the scleral insertion, that little X, is maintained constant relative to the location of the pulley, which is represented by the little round ring that you see on your left. The inferior oblique pulley, however, has to move by a different amount. In order to maintain its half-angle behavior, the inferior oblique muscle pulley needs to be moving only 1/2 of the distance of the inferior rectus pulley, as seen here. The inferior oblique is schematized by the yellowish band and the inferior rectus by the teal band as the eye looks up. The superior oblique, therefore, is a special case because its pulley is rigid. In the axial view that you see on the left, you see that large reflection in the trochlea, schematized TR. And in the coronal view, you can see the trochlea TR in the upper left of the right panel. And to the right of the trochlea, the tendon becomes thin and ultimately difficult to distinguish by imaging like this from the surface of the sclera, which has an identical signal. This is a coronal view then that summarized what I told you a little bit earlier about the interaction between contraction of the inferior oblique muscle and the position of the vertical rectus pulleys. Again, we have the horizontal coordinates on the x-axis, the vertical coordinates on the y-axis of the 4 rectus pulleys. Note that in upward gaze, the lateral rectus pulley shifts downward, that's in superduction with the filled triangle, and in infraduction, upward gaze, the lateral rectus pulley shifts upward, and that is because the inferior oblique muscle contracts in upward gaze, and it is coupled via its orbital layer to the lateral rectus pulley. Similarly, the inferior rectus pulley shifts nasally in upward gaze, superduction, and temporally in infraduction because of its coupling to the orbital layer of the inferior oblique muscle. So, to summarize the important things that I've told you, each of the extraocular muscles has 2 layers. A global layer that rotates the eye because it's directly inserted on the eye, an orbital layer that manipulates the position of the extraocular muscle pulleys. The functionally significant pulleys are in the lower right. They're posterior to the globe, and they consist of encirclements of collagen, elastin, and smooth muscle. And these pulley encirclements are supported by connective tissue bands, a particularly important one being the LR-SR band ligament between the superior rectus and lateral rectus muscles. Because the oblique muscles insert on rectus pulleys, there is an interaction that can be thought of as a concept like nested gimbals. Gimbals are suspensions for spheres or rotational suspensions. The 4 rectus muscles seen in green constitute the rectus inner gimbal that is rotated in a manner corresponding to the yellow arrows by the action of the oblique extraocular muscles. So the inner gimbal implements Listing's law, the ocular kinematics that I talked about before. The outer gimbal allows violation of Listing's law by rotating the position in the coronal plane of the 4 rectus pulleys. And that is important to reflexes like the torsional vestibulo-ocular reflex, which we test clinically in the head tilt test. Now, here's an example of head tilt testing during MRI scanning in a normal individual. The purplish axial images are actually correct relative to gravity. This was done with a 90-degree right head tilt in the upper pair and a 90-degree left head tilt in the lower pair. That's by on-side decubitus positioning in the scanner. The heat-mapped images seen in yellow, orange, and black have been rotated for comparison and have been obtained at the anteroposterior level of the rectus pulleys. And I'm going to draw lines through the center of the 4 rectus pulleys, from the lateral to the medial and the inferior to the superior rectus pulleys, so that you can better appreciate the effect of gravity on the location of the pulleys. Note in the right orbit that's seen in your left column that the lateral rectus pulley is superior to the medial rectus pulley, but it shifts downward in left head tilt. And the superior rectus is nasal to the inferior rectus in right head tilt, but is temporal to the inferior rectus in left head tilt. So the rectus pulleys are twisting in their orientation around the line of sight in response to the head tilt. Now, in examining 19 orbits of normal individuals, we can look at the horizontal, the pulley coordinates and the x-axis, the vertical coordinates of the pulleys on the y-axis. These are in millimeters, and we can see that systematic counter-rotation of the location of the pulleys in response to this normal head tilting. This is a torsional vestibulo-ocular reflex. And it's implemented by the oblique extraocular muscles. When we look at the cross-section of the inferior oblique muscle, which is a good marker for its contractility, the inferior oblique changes from a smaller to a larger cross-section during that ocular counter-rolling. And the superior oblique muscle is also active. We see in that upper right graph evidence of that. With the ipsilateral side down, the superior oblique is larger than with the contralateral side down. Convergence is another situation where we have torsional repositioning of the extraocular muscles. This is a situation in which the target was aligned on the left eye and all the converging was happening in the right eye. And I did this experiment in order to make a point so that we could eliminate the effect of any changes in horizontal and vertical position from the effects of torsion. Notice during convergence, when the right eye is turned in, the Helmholtz mechanism of accommodation in this young adult, the thickening of the lens of the eye, accommodative convergence was going on. This is a case in which the target was aligned on the left eye and all the converging is done in the right orbit as seen in that left column. Notice the optic nerve swings temporally as that right eye converges, but there's no change in the position of the optic nerve in the left orbit. But what you do see is a twisting of the pulley array around the line of sight. During convergence, the superior rectus pulley shifts temporally, the inferior rectus pulley shifts nasally, the medial rectus pulley shifts superiorly or upward, and the lateral rectus pulley shifts downward. A lot of things are changing in that left orbit, even though horizontal and vertical eye positions are not changing. This is an example of that convergence, and you can see that the thickening of the inferior oblique muscle, which is seen at the bottom, corresponds to its contraction that is excycler rotating the eye during convergence when the lens thickens. We're now going to shift gears from the connective tissues to the innervation of the orbit, another modern concept. This is a concept of compartmentalization of the extraocular muscles and the ability of the brain to differentially control different parts of extraocular muscles. The simplest concept here involves the lateral rectus muscle, which is controlled by two different divisions of the abducens nerve. The abducens nerve divides into a superior and inferior division just before entering the muscle. And within the muscle, it arborizes, each division arborizes to innervate a territory that does not overlap the territory of its corresponding fellow, as seen here in this three-dimensional reconstruction that we published of the intramuscular abducens nerve in the human. The same is true of the medial rectus muscle. The medial rectus motor nerve has a superior division seen in green and in magenta, an inferior division, and these two divisions innervate territories of fibers that don't overlap. So it's possible for these two nerve divisions to control different actions, to command different actions in different parts of the extraocular muscles. And that indeed happens, and that concept is a nice modern one that you should know about. Because it should therefore be possible to generate torsional and vertical actions from, for example, horizontal rectus muscles by differentially activating the superior zone of fibers or the inferior zone of fibers, given that the typical width of a horizontal rectus muscle is around 10 or more millimeters wide. The fibers are inserting in entirely different places on the sclera. This makes it possible for the brain to add to the repertoire of actions beyond the primary, secondary, and tertiary actions with which I introduced this lecture. Now, how is that important clinically? Let's look first at the issue of lateral rectus paralysis. Here's an example of a patient who has complete paralysis of the left lateral rectus muscle with deficient abduction of the left eye as seen in the lower photograph. Magnetic resonance image findings of paralysis of the lateral rectus muscle are stereotypic when the muscle is completely paralyzed. One sees marked atrophy of the cross-section of the muscle, as seen in this paralyzed left lateral rectus muscle, with an absence of contractile thickening on attempted gaze in the field of action of the muscle, and finally, displacement of the muscle against the orbital wall, as seen in the lower two panels for the left orbit. The normal right lateral rectus muscle has a pad of fat both on its orbital and global surfaces, whereas the paralyzed lateral rectus muscle is directly apposed or plastered against the wall of the orbit. The paralyzed lateral rectus muscle exhibits this behavior in axial views as well. On the left side, you see the normal path of the right lateral rectus muscle, but you can see the thin left lateral rectus muscle in the posterior orbit is pushed against the wall of the orbit, and only at the pulley more anteriorly do you see the inflection anterior to which the thin tendon continues toward the scleral insertion. The whole muscle cross-section is paralyzed in this case. But many cases of lateral rectus weakness do not involve both regions or compartments of the lateral rectus muscle. There is often selective atrophy of one compartment more than another. And that selective atrophy more commonly involves the superior half of the lateral rectus muscle than the inferior half. Here we see a weak left lateral rectus muscle seen in that rightward column, where the atrophy is primarily in the superior part of the muscle. Only the superior part of the muscle is pushed against the wall of the orbit, and there's relative preservation of the inferior half of the lateral rectus muscle. This patient will typically exhibit preservation of some abducting action of the lateral rectus muscle, and beyond that, a tendency for the eye to infraduct or become hypotropic in the area where abduction can be achieved. In this case, the pathology was a benign tumor of the abducens nerve. When we looked at 39 cases of lateral rectus weakness, we were able to identify ipsilateral hypotropia in 15 of these 39 cases, so approximately 35 to 40%. Notice these 6 examples. The asterisk indicates the case of the superior compartment palsy, atrophy of the superior part of the muscle, relative preservation of the inferior part. These patients will tend to have some abduction, but not complete abduction, and this may be important to modifying your surgical plan for correction of the patient's resulting strabismus. I said that torsional and vertical actions may come from differential contraction of the superior versus inferior compartment of the lateral rectus muscle, and this indeed does happen in many cases. Let's now talk about superior oblique palsy, because compartmentalization is important here. We were able to validate, in collaboration with a group at Johns Hopkins, that subarachnoid denervation of the superior oblique muscle rapidly produces atrophy of the involved superior oblique muscle within as little as 6 weeks. It goes to completion. So here we see a left superior oblique palsy there. Notice the normal right superior oblique has a good cross-section. It is much smaller on the left side. But because this is an experimental animal, I was able to do histological examination. And in this case, the denervated superior oblique muscle shows a reduction about 50% in cross-section, with that reduction primarily being in the global layer fibers, relatively sparing the orbital layer fibers of the superior oblique muscle. So atrophy of the superior oblique muscle is a very reliable and rapidly developing objective finding in superior oblique palsy. Compartmentalization complicates the mix, because The medial compartment of the superior oblique muscle is contiguous with fibers that insert near the equator of the globe and in primary position thus have predominantly encycloducting or torsional action. The lateral fibers are contiguous with the fibers of the tendon that insert posteriorly to the globe and primarily have an infraducting action in central gaze. The trochlear nerve in the human has two divisions, a medial division and a lateral division, whose intramuscular arborizations, as reconstructed here, do not overlap. So the brain has the possibility of selectively activating mainly the torsional versus mainly the vertically acting fibers of the superior oblique muscle. Here again is a prosection of the orbit after unroofing the bone and reflecting the superior oblique muscle superiorly, as you see in the upper left. We can see the medial belly of the superior oblique muscle has been marked with dark marking sutures. We see the trochlea, and we see the reflected tendon run posteriorly to the insertion, with the anterior fibers that are marked with a black suture and the posterior fibers marked with a white suture. As I showed you before, you can resect this en bloc, maintaining its polarity, and remove the trochlea. And we see here that the medial belly fibers of the muscle are contiguous with those fibers that insert anteriorly and thus near the equator of the globe for an encycloducting action. The lateral belly fibers are contiguous with the posterior fibers that insert posteriorly and produce predominantly a vertical action. So it is possible that the brain can selectively activate torsional and vertical components of the superior oblique's action. But that's not the most complicated consequence of some of this new anatomy. Some of it involves clinical diagnosis of superior oblique palsy and the concept of masquerading superior oblique palsy. Now, in the upper two coronal panels, A and B, we see a case of actual superior oblique palsy, where in panel A, we see very tiny cross-section to the residual nub of the superior oblique muscle. And in panel B, on the left orbit, we see a nice, robust cross-section of the superior oblique muscle. The prism cover alignment measurements are seen in panel C. There is a right hypertropia, as you would expect. The right eye is higher than the left. That hypertropia increases in left gaze because the vertical action of the superior oblique muscle is greater in adduction. The hypertropia is greater in downward gaze because downward gaze is the field of action of the superior oblique. And with rightward head tilt, the hypertropia is 25 prism diopters and only 2 prism diopters with left head tilt. This constitutes a positive Parks-Bielschowski three-step test that's classically been interpreted for superior oblique palsy, and in this case, the interpretation is quite correct. But we have a young lady of exactly the same age seen below, in whom both the right, seen in panel D, and the left, seen in panel E, superior oblique cross-sections are exactly normal, and the superior oblique muscle contracts in downward gaze. In this situation, there is also a right hypertropia of 12 prism diopters, decreasing in right gaze and increasing to 16 in left gaze, and also increasing in downward gaze, even to a greater degree than in the case of the superior oblique palsy above. The hypertropia is 12 prism diopters in right head tilt and 6 prism diopters in left head tilt. This case, too, fulfills all 3 steps of the Parks-Bielschowski three-step test, and yet, objectively, there is no abnormality of the superior oblique muscle. So we've termed this situation masquerading superior oblique palsy. Now, it is possible to correlate the contractility of the superior oblique muscle with its cross-section in central gaze. And here we define contractility as the change in maximum cross-section of the superior oblique muscle from upward gaze, in which it's small, to downward gaze, in which it contracts and is larger. So the normal controls, whose graphs are plotted here in the white squares, will fall near the right side of the superior oblique's cross-section axis and near the top of the vertical axis, which is the contractile thickening. The yellow circles represent the superior oblique behavior contralateral to an ipsilateral superior oblique palsy. That's the normal side. And note that those yellow circles overlap the normal distribution in the upper right quite nicely. But patients with superior oblique palsy have both a small superior oblique muscle in the lower left and one that doesn't contract very much. Masquerading superior oblique palsy cases are those illustrated here in the filled triangles that have both normal cross-section and normal contractile behavior overlapping the normal controls in as black squares. The masquerading cases are seen in the lower left, in which the size of the muscle is small and the contractile behavior is small. The learning point here is that a positive three-step test alone does not guarantee that you have any deficiency of the function of the superior oblique muscle, because many other factors could be contributing to the alignment behavior. Let's talk a little bit about pattern strabismus here, because we see this frequently in young children, and it's often related to the anatomy of the orbit. Here's a case of congenital A pattern strabismus. Notice the esotropia in upward gaze and the lesser esotropia or even orthotropia in downward gaze, but the marked over-depression in adduction seen in the bottom row and the marked under-elevation in adduction seen in the upper row. When you image in the coronal plane at the level of the pulleys, in such cases, we see that the LR-SR band ligament is intact, but that the lateral rectus pulley is superior to the medial rectus pulley in both orbits, and the superior rectus pulley is nasal to the inferior rectus pulley in both orbits. Now, what is the consequence here? Well, the medial rectus muscle is acting as an infraductor in adduction, and the lateral rectus muscle is acting as a supraductor in abduction. The inferior rectus muscle is an abductor in downward gaze, and the superior rectus muscle is an adductor in upward gaze, corresponding to the A pattern of strabismus without invoking any abnormality of the oblique muscles at all. This is the typical lid configuration, congenital A pattern heterotopy or misplacement of the pulleys. Notice that the lateral canthus is superior to the medial canthus in both eyes, and if you draw lines connecting the two and draw the perpendicular, it inscribes the letter A for A pattern strabismus. The lid fissures usually correlate with that pattern. Conversely, V pattern pulley heterotopy is illustrated here, with marked over elevation of the eyes in adduction and under depression of the eyes in adduction, associated with a V pattern strabismus typically. So here we have imaging at the level of the pulleys. If we draw lines through the center of the horizontal rectus pulleys, you see here that the medial rectus pulley is superior to the lateral rectus pulley in both orbits, and the superior rectus pulley is temporal to the inferior rectus pulley in both orbits, so that in adduction, the medial rectus is acting as an elevator, and in abduction, the lateral rectus is acting as a depressor. The superior rectus muscle is abducting the eyes in upward gaze, and the inferior rectus muscle is adducting the eyes in downward gaze, giving rise to the V pattern without necessarily invoking any oblique muscle abnormality. How do the lid configurations correlate? If you draw a line between the superior and inferior canthus and then draw its perpendicular, it inscribes the letter V, which frequently correlates with the pattern of V pattern esotropia in these cases of pulley heterotopy. Here's a more extreme example where both orbits are very extremely excyclorotated, producing a very large V pattern that didn't respond at all to oblique muscle surgery. Not all pulley abnormalities are congenital. A very common form occurs as a result of age-related degeneration of the LR-SR band ligament, which is intact in these coronal histological specimens of human orbits at 17 months and 4 years of age. But by 57 years and 93 years of age, the bands have become thin or ruptured, and we can see that relative to the center of the globe, the lateral rectus pulley is shifting progressively inferior to that yellow line, making the lateral rectus muscle somewhat of an infraductor as well as an abductor. Because of this downward sag of the rectus muscles, this has been termed the sagging eye syndrome, the sagging eye syndrome. What is the clinical evidence of this syndrome? And the clinical evidence is usually good enough to make the diagnosis. We typically see a patient over the age of 40 years with a history of blepharoplasty or blepharoptosis. Not that those surgeries cause it, but that they're usually required because of the patient's adnexal sag. They typically have eyelid bags, floppy lids, and they have an elevated upper eyelid crease or a prominent superior sulcus defect. MRI scanning shows age-related degeneration of the LR-SR band ligament if you do it. This is a young individual with a robust LR-SR band. Here we see an older orthotropic individual in which it's thinned and the lateral rectus is shifted downward a little. And here we see an older individual with a ruptured LR-SR band who has developed strabismus. If the downward sag of the lateral rectus occurs in a bilaterally symmetrical manner, the patient is prone to exhibit divergence paralysis esotropia, which can also be termed age-related distance esotropia. Here we see these coronal MRI images. This line, the green line, is through the center of the medial rectus pulley, and notice that the lateral rectus cross-section has shifted inferiorly in both orbits so that its top is just kissing that green line, and the LR-SR band ligament is bilaterally ruptured. The vertical consequences will cancel, but some of the abducting action of each lateral rectus muscle has been lost, leading to distance esotropia. If this occurs asymmetrically, cyclovertical strabismus will result either alone or in conjunction with esotropia. Notice here the green line through the center of the medial rectus muscle also incorporates the lateral rectus on the right side. The LR-SR ligament is degenerated bilaterally, but the downward sag of the lateral rectus muscle is greater in the left orbit, and there is approximately a 45-degree inclination in the path of the tendon. This results in left hypotropia and excyclotropia, with greater excyclotropia on the side of the lower eye in sagging eye syndrome. You can recognize the clinical evidence of this. There is frequently disinsertion of the levator tendon from the tarsus with superior sulcus defect and ptosis, high lid crease, and blepharoptosis. The sagging eye syndrome should be distinguished from the heavy eye syndrome. The heavy eye syndrome is a syndrome of limited abduction and superduction in the setting of axial high myopia. Thus, there will be hypotropia and esotropia, but significant limitation to abduction. As you see here, there is no abduction of the left eye beyond central gaze, and the patient really can't look up, especially with the right eye. The quasi-coronal MRI seen at the bottom shows the reason. The lateral rectus muscle has shifted inferior to the globe, coming to lie almost parallel with the path of the inferior rectus muscle, as the globe has correspondingly shifted supratemporally in the orbit. The heavy eye syndrome needs to be recognized because it does not respond to conventional strabismus surgery very well. So here's an example of the heavy eye syndrome with high-quality coronal MRI throughout the orbit, beginning in the deep orbit in the upper left and continuing from left to right and top to bottom more anteriorly in the orbit. But the key finding here, as demonstrated by Yokoyama, is this one. A line connecting the superior rectus pulley to the center of the globe, and thence from the center of the globe to the lateral rectus muscle, will inscribe an angle much greater than 90 degrees. Typically around 120 degrees, and the lateral rectus muscle tendon is hugging the surface of the globe without any gap. That is typical of the heavy eye syndrome. In the sagging eye syndrome, we see two differences. First of all, a line connecting the superior rectus pulley to the center of the globe, forming a 90-degree approximately angle to the lateral rectus muscle, is a much tighter angle. And there is also a fat gap between the lateral rectus muscle and the surface of the globe, so the lateral rectus muscle is not hugging the globe. This is typical of the sagging eye syndrome, which responds well to conventional strabismus surgery, such as medial rectus muscle recession. So let me summarize the difference between heavy eye and sagging eye syndrome. The photographic example is a patient with extreme myopia with heavy eye. Sagging eye syndrome can occur with or without axial myopia. There's an infratemporal shift of the lateral rectus muscle, a temporal shift of the inferior rectus muscle, no shift of the superior rectus, and the lateral rectus is displaced or distracted away from the globe, separated by a little bit of fat. The heavy eye syndrome, illustrated in this picture, is associated with axial high myopia approaching 30 millimeters in axial length, with an infranasal shift of the lateral rectus muscle, nasal shift of the inferior rectus, infranasal shift of the lateral rectus, hugging the globe, a nasal shift of the superior rectus muscle, and often a supratemporal shift of the whole globe relative to the muscle cone. Thank you very much for your attention.
Joe, that was absolutely fabulous. I am sure this is a lecture that people will not only enjoy hearing the first time, but there is so much practical information in it. I think people are going to listen to it over and over again. Really amazing contributions. I do have 2 questions for you, if I may. In the course, let's say, of an average, if there is such a thing, operating week or a month for you, what percentage of your cases now are you doing things other than recessions or resections or plications or maybe transpositions? How often are you actually operating on the pulleys?
You know, Bert, probably not so often, because in the half of my cases now are these older adults with sagging eye syndrome, and the pulley suspensions are just falling apart. So I like to just stay away from them. So I've gone more and more to operations under topical anesthesia, minimally invasive stuff, and I find that it's valuable to understand what the pulleys are, what they do, but difficult to change them. I had thought that we could correct these big A and V patterns by moving the muscle paths. The pulleys are tough to move by conventional strabismus surgery. I think with orbital surgery, we can do something with them. I do pulley posterior fixation maybe once every other week by just putting a suture from the muscle belly to the pulley. So that I do fairly often. I consider these posterior fixation operations to be pulley operations because they do offset the pulley, although you don't have to understand that to get a good effect. I mean, you can use a different rationale and do the operation well. But I don't, when I do transpositions now, I don't disinsert the muscle. I just go back and suture the muscle belly where I want it to be on the equator.
Like the Nishida procedure, for example.
Exactly, the Nishida procedure,
Yeah.
Or modified Nishida procedure. So I'm, doing that, and I guess I haven't looked at whether that moves the pulley. But with Art Rosenbaum years and years ago, we looked at the pulley position changes after a tendon transposition with augmentation of Alan Scott. It's got to be similar to that because the posterior sutures are placed in about the same area. So I don't directly do surgery only on the pulley. I had been doing some equatorial myopexy. Robert Clark talked about that, but found that was pretty unpredictable. So I do less radically innovative surgery based on pulleys than I thought I was going to do.
Okay. The other question I have is related to the really amazing observations about compartmental innervation. As you know, with the slanting procedures, both for pattern strabismus or distance near discrepancies, there's this interesting paradox that people will approach it in exact opposite manners and perhaps get good results. For example, for a V pattern esotropia, the original slanting procedure would have been to recess the superior pole of the medial rectus back further than the inferior pole, and that's based on a biomechanical explanation. And more recently, many people are doing the opposite. They're slanting the inferior pole further back for a VET. And it was said, well, can compartmental innervation explain that? Has it been shown that the inferior compartment in the medial rectus is innervated more in down gaze than up, and similarly more at near than distance?
Yeah, I actually have looked at the compartmental innervation, and the medial rectus contributes a little bit more in the superior compartment to upward gaze. There's a very small effect there. The lateral rectus muscle compartmental innervation seems to be important in ocular counterrolling. That was a surprise to me, but I'm glad to see that. It's the superior compartment of the medial rectus muscle that seems to be more active in convergence. And
which, if I understand, would be contrary to the hypothesis people are using of slanting the inferior pole back further for convergence in excess esotropia.
yeah, you've been a voice of sanity on this whole controversy, pointing out that you can't argue it from both opposite perspectives and claim they both work for the same reason.
Right. Okay.
I don't understand what's going on here. I'm not satisfied that compartmentalization provides a decent answer, other than people wave their hands and say compartmentalization, so here's why my operation works. But I don't know why it should, based on what I know of compartmentalization. So this is where we are, though, I would like to understand it. So I have a joint grant with this bioengineer at George Mason University, who's got really good programming capability. We're trying to get beyond Joel Miller's model, which only had one compartment, didn't have orbital and global layers.
Right.
So we have a model that has superior compartment, inferior compartment, and orbital layer for all the muscles.
And one other thing to factor in is that sarcomere remodeling should negate the effect of slanting. And
well, you've made a good point about that too. If you argue this sarcomere remodeling concept long enough, it runs in circles and makes no sense to me. Okay.
Agree. Maybe on that note, we should wrap it up. Joe, I want to thank you so very, very much. And this was wonderful. I know you're busy, and I appreciate you taking time to do this. And viewers, if you enjoyed this as much as I did, I hope you'll be tuning in to the other lectures as part of this series. And with that, depending on what part of the world you're viewing this from and what time of day, I'll wish you good night, good afternoon, or good morning.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Bert Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the board of directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course, both visually and auditorially, extraordinary, and for their technical guidance of the lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.